Good morning from the Hawaiian Eye Conference in the Big Island of Hawaii. We're pleased to be here today with Dr. Jay Pepose from St. Louis, Missouri. Thanks a lot for being with us this morning.
My pleasure. Thank you.
I'd like to speak with you this morning about a really challenging clinical topic, which is neuropathic pain. We know that people can have eye pain from ocular surface disease, but that some patients have sort of a more deep pain related to neuropathy on the corneal surface. How does this play into our management, especially when dealing with cataract surgery?
Well, there's many patients who do develop pain after cataract surgery, and the nature of the pain, the neuropathic pain, is often very different. These patients complain of sensitivity to light, sensitivity to touch, sensitivity to wind. Sometimes they'll even talk about a spontaneous electric-like pain, and it may become chronic. And the other thing that distinguishes them is, I call this the high pain, no stain syndrome, and that they have almost no signs of ocular inflammation, and yet they have an intense pain. Many of them also have overlapping pain syndromes. For example, they may have fibromyalgia, migraines, inflammatory bowel disease, autoimmune conditions, post-traumatic stress. So, and they're sensitive to pain not just in their eye, but even dermatomal pain.
So how then do you approach this type of scenario, Jay? Because it seems to be a challenging scenario that may not respond to our typical dry eye pain treatments, such as prescription eye drops like cyclosporin, lifitegrast, or omega supplements, tear duct plugs, artificial tears. These are sort of like our go-to treatments for surface disease, but it sounds like these type of patients may not necessarily respond to that type of treatment.
Exactly. So I think that the first thing that I'd like to do in evaluating these patients is try to differentiate, is their pain, they have a new threshold for pain. It could be their peripheral neurons are firing spontaneously to stimuli that would be innocuous to us. And it could be that they're central. So what I do is a proparacaine test. I give them a drop of proparacaine, and I said, does the pain go away completely or partially or not at all? If it goes away completely, we know it's the peripheral nerves. And if in peripheral nerves, I start to treat them with autologous serum in combination with steroids, and oftentimes they have enough plasticity that it does go back. The patients that are more mixed or more central, they need to be treated with either tricyclic antidepressants, pregabalin, gabapentin. They may also benefit from anti-inflammatory treatment, however, and even what we would consider non-conventional treatments. For example, just a regimen of exercise, a regimen of anything they could. There are other methods that can be applied.
Other things such as dietary changes, acupuncture, and other sort of non-traditional treatments that may help as well.
Exactly, because they seem to affect the threshold for firing, and there is this plasticity, so we could model it, we could modify it.
Yeah, I find that sometimes this patient scenario is one of the more challenging ones, because they may be coming to you as a fourth or fifth or sixth opinion because they've tried all the sort of traditional therapies without much improvement, and they're a bit frustrated by the process that no one has been able to provide them with relief. So how do you counsel this patient by instilling confidence that you are going to try to help them, but with a little bit of hedging your bet and not really committing or guaranteeing that you may get a positive result?
Well, I think it's important, I think, to recognize, to empathize and explain to the patient, this is a syndrome, you're not making it up, I understand it, I hear it, it's been described, there are treatments for it. It can be confirmed, for example, with in vivo confocal microscopy. Often you would see microneuromas and neuronal changes, so it can be confirmed in sort of an optical biopsy. But many of these patients do respond. Sometimes it is worth working in conjunction with pain management because some of us are not that familiar with some of these oral medications and side effects. And in fact, some patients have even gone, the extreme group have gone to transcranial stimulation and other treatments of that nature. So I think the first thing is just acknowledging that this is real, because they gone, as you said, they've gone to optometrists and ophthalmologists who examine them, and there's hardly any signs. And so, people just wonder, is this, are they making it up?
Yeah. Well, one of the more important things, Jay, that I think you mentioned is validating the patient's concerns and the patient's complaints. And, certainly now we have more understanding of this type of syndrome than we had 5 or 10 years ago. And hopefully 5 or 10 years from now, even more knowledge will continue to be progressed in this front. Thank you so much for sharing your expertise today.
Thank you for having me.